received. Dr. Jane, where do you send your patients to obtain an at-home sleep study, and how much does this cost?
So I'm gonna put that back to Dr. Pujo because I actually don't conduct the home sleep study. I get the dentist's office does the home sleep study.
We don't send them anywhere because we have the equipment, the home sleep test in our office. So we have sleep image system and also the apnea link. How much it costs? We charge $150 if the patient decide on using the apnea link, and $200 using the sleep image, and that includes Dr. Jane reading the data and the diagnosis.
Let me just throw my 2 cents worth in by saying I have a similar problem in London. I'm 2 hours from Toronto. We have a private PhD facility and a public one, and the waiting list is quite long, of course. There was a time when I worked with a sleep physician in town who wanted quicker turnaround. So we would see his patients on a very specific request to do home sleep study and had it validated. I believe we charged $150 or so. I only have the MediBite. That was a great system while it worked. Things are changing rapidly, but for the dentists who don't have access to home sleep study, I totally understand the question. And I think you answered it well, Dr. Pujo. So let's go on to the next question. Is there a network of MDs we can connect with that believe in multidisciplinary care? Maybe a Facebook group. Is there a network of MDs we can connect with that believe in multidisciplinary care? Perhaps a Facebook group. Let's ask Dr. Jane first.
I'm not aware of a Facebook group. I think most of my colleagues are open to working in a multidisciplinary setting. It's just not something that they're used to doing. It's a little different because I'm a family physician that does sleep medicine, so I can accept a referral from a dentist. So if you're a respirologist or a neurologist doing sleep medicine, you do need a referral from a family physician in order for them to get paid. So we've solved that issue at Sleep Care Hub by creating a referral through me or through other family physicians to the other sleep physicians that work with us. But the issue isn't that they're not willing to work in a multidisciplinary format. The issue is that they're not able to do a consultation. I can because I'm a primary care physician. So,
well, that's very good of you to tell us the inside story at your office. As I said, I'm in London. It's a dental school town, a medical school town. I'm well known. I have lots of needs to connect with specialists, but you got to go through the family doc, who I think are just so darn busy now. They can hardly take your phone call. And I guess my big question, Dr. Jane, is there any movement at a higher level to understand on the part of OHIP and the Medical Association that this referral system is broken, and we as dentists who are part of the healthcare team should be allowed to refer directly to medical specialists? Is that being discussed? Has it ever been discussed? Is it going to see the light of day, or is it the same old?
I totally agree with you, and unfortunately, it's still the same old.
Okay, thank you. Next question. Are there simple chairside evaluations that I can do to see if a patient complaining of tinnitus is primarily due to TMD?
Yeah, so in my experience, there's no bedside, either medical or dental exam that is going to differentiate tinnitus from one cause or the other. You would need to first consult with the ear, nose, and throat surgeon to make sure the hearing is normal. If the hearing is normal and there's no other obvious cause of tinnitus, like taking anti-inflammatories or other medications like aminoglycosides that can cause tinnitus, then you can start thinking about TMJ as a possible cause. Of course, you can do that concurrently. While they're sitting in the dental chair, you can also ask about questions related to sleep disordered breathing and TMJ. And if there is evidence of TMJ dysfunction, then at least part of the tinnitus may be contributed to by TMJ.
Okay, thank you. A related question, can OSA, obstructive sleep apnea, cause or contribute to hearing loss? Can sleep apnea contribute to or cause hearing loss?
I see my friend and colleague, Dr. Morong, and perhaps both for the last question and this question, if she would do me the pleasure of answering them, that would be fantastic.
Sure, no problem. Yeah, I agree with what you've said. Pretty much we don't have any extensive detailed specific examination. We would do a very cursory, palpation of the TMJ joints with mouth opening to see if there's any crepitus or clicking that's happening, looking at their mouth opening. But beyond that, even and I think most of us ENTs, once we've kind of ruled out that hearing loss is a cause for the tinnitus, then I usually counsel patients to say the second most common thing is that there may be an underlying, TMJ problem that's happening. And then I would refer the patient on to a dental specialist like Dr. Pujo, who specializes in this. And sorry, you said the next question was, can sleep apnea cause hearing loss? Not to my knowledge. There are two basic types of hearing loss. You have the conductive type of hearing loss, where there's a physical blockage or damage in the ear itself, or what we call sensory neural hearing loss, where there's damage to the nerve, either from a tumor or ischemia. You can look at very indirect ways that sleep apnea can cause it, but there's no direct cause of hearing loss from having sleep apnea.
Thank you, Dr. Morong, and thank you for jumping in and being here to help us. You won't see my face because I've blown up the chat box, so I don't have to squint so hard. Dr. Pujo, what HST are you using? I've not seen one that uses a ring before. Now, this is going to be an introduction to our next few weeks, but Dr. Pujo, tell us about the ring.
Yeah, so this is the screen you've put on is called VivoScore, but it's powered by Sleep Image. The parent company is Sleep Image, and it's a system based on cardiopulmonary coupling. So sleep is not just assessed by looking at the brainwave pattern, but there is an algorithm using cardiopulmonary coupling. It's been around for 7 or 8 years as a concept, and the Sleep Image ring as a consumer device has been tested in the Boston hospitals and validated against PSG, and has shown promising results. When I've looked at Sleep Image reports from Dr. Pujo's office or elsewhere, and then patients have severe sleep apnea and they want CPAP covered by their ADP, they need an in-lab study. And when we do the in-lab study and compare the results to Sleep Image, they're quite comparable. But that is, the device is called Sleep Image. It is not a huge expense for a dental office to purchase one. I think it's to the tune of 300 American, and each test technically, the technical auto-scored test is also not that expensive. Probably the most expensive part is the physician interpretation, to be honest. But anyway, that's what that ring is. I see there's another question. Is it similar to the Aura ring? No, it works on a totally different system. And to my knowledge, Sleep Image is the only ring-based device currently out there that's been validated against PSG. It is Health Canada and FDA approved.
Can a dentist located in Vancouver get access to the sleep image ring and have diagnostics made for their patients by Dr. Jane and his team? Dr. Jane.
The answer is yes, because we have other members of our team that are licensed in most provinces, including British Columbia and Alberta.
Excellent. Next question. Why do some people notice a significant improvement in their sleep using oral appliance therapy for the first few nights and then all of their symptoms reoccur?
I think Dr. Jane and I already discussed this, why in some patients, they notice a lot of improvement in the first few days of the oral appliance. And Dr. Jane made me understand why after a few days, their symptom is actually worse. The main reason is because they sleep better, so that everything is collapsing more. Did I understand that correctly, Dr. Jane? Because we talk about this.
I'm not sure. So I really can't answer the question why someone would notice the beneficial effect initially, and then that effect doesn't persist. So I think we're talking about a different case. To be honest.
Okay, thank you. This is a question to Dr. Morong. Based on my experience talking with adult patients with grade 4 tonsils, most ENTs are reluctant to take these out in adults. Is this true? Is this a very risky procedure in adults? Is this procedure underpaid in Canada as it is in the USA?
So yeah, we have main indications for tonsillectomies or taking out tonsils have gone through a spectrum in history. It's gone from, everyone has gotten their tonsils out on a kitchen table to no one wanting to remove tonsils simply because you do have complications of post-operative bleeding and pain and whatnot. Now we've kind of come back to a balance where the main indications for removing tonsils are one, either if a patient's had recurrent infections requiring the need to remove it, or typically in children if they have sleep apnea. Now, because children do very well after removing their tonsils and adenoids when it comes to sleep apnea, it's widely done. There's usually no question. If we see grade 4, which really means basically the tonsils on either side are kissing each other, they're that big, that removing the tonsils will definitely improve a child's sleep apnea. It becomes more complicated in an adult where we don't see the success rates may not be as good because there may be other anatomic factors, soft tissue collapse, the bony framework with Dr. Pujo looks at, may have all kind of, it all contributes at that point in an adult. So it's not as simple. So that's one reason why the success rates may not be as high if the indication is snoring or sleep apnea. And also the complication rate is higher in an adult. So the rate of post-operative bleeding is higher in an adult, and adults have a lot more pain than kids do. You take out tonsils in a kid and they're sucking popsicles and riding on a train the day of the surgery, but an adult can lose 10, 20 pounds because they're in so much pain for 4 to 6 weeks sometimes in extreme cases because of the pain. And when they're in pain, they don't drink. And when you're not hydrated, it becomes very dry, increases the risk of bleeding. And adults, and the surgery in general is just a bit more cumbersome in adults. So that's why you'd have a lot of ENT surgeons be a bit reluctant to remove tonsils in an adult compared to a child. I can't speak to the fee schedule when it comes to the US versus Canada. I think Pramila left already, but the question about why do some people notice a significant improvement in their sleep using the oral appliance therapy in the first few nights,
Right.
and then their symptoms come back. What I've seen from sleep endoscopy in patients who experience that, and this may not be the cause for everyone, but patients who experience that or who are just non-responders to oral appliance therapy in general, is that when we do sleep endoscopy and we simulate the oral appliance with the mandibular advancement, we see that everything opens up really well at the level of the tongue base, but they still have some obstruction either higher up at the palate or lower down at the epiglottis. So what's happening with those patients is that they are getting improvement, right? And that partial improvement is significant for them because they've never experienced that improvement before, but it's still not complete improvement. So after a few nights or a while, they go back to a baseline of, well, I'm still feeling tired. I'm still having the symptoms that they had before, but it's just because they kind of went one notch up from their baseline that their perception is that they have improved.
Thank you. Okay, any oral questions? Open your video screen, open your mic, raise your hand, and we'll let you ask that question directly to any of our now 3 guests tonight.
I'd like to add a question.
Okay, Dr.
Sorry
Joe.
about that.
I
My
can't.
question is to about the sleep image and asking if the ring device is predicated on ODI.
Who would like to answer that question?
Oh, it's not predicated on ODI. It is based on cardiopulmonary coupling, and it has its own separate algorithm.
And,
Okay.
and it's getting it through the blood flowing through the finger.
That's right.
And
Right.
we have Sola on here as well, if she has any. Thank you, Dr. Jane. And if there's any other questions, I see Sola's there as well.
Okay,
Hi all. Thank you for inviting me. I've enjoyed listening to your lecture and your questions. My name is Solveig and I'm the medical director for Sleep Image. That is the parent company that has developed this cardiopulmonary coupling algorithm in cooperation with Beth Israel Medical Center, the sleep division, over the past 10 years. The idea is that if you think about it, sleep is conducted in the midbrain, and we are used to recording sleep from the surface of the brain. This is actually a very old technology that was invented by Dr. Hans Berger in Germany in 1930. So if you think about the atmosphere when he invented this technology, that was very, very long time ago. We know now that you can as well measure sleep from the autonomic nervous system, because in both cases you're deriving measure of sleep. You're not measuring actual sleep with polysomnography, nor with the cardiopulmonary coupling. The technology is FDA cleared, both to be used in adults and children. It has been published in over 80 peer-reviewed publications. This is the only technology that I know that has an FDA-cleared sleep quality index, which is, to me, an interesting addition to the apnea-hypopnea index. That is a prevalence index and doesn't necessarily correlate very well with the symptoms of patients. So I think in the future, now we have the sleep quality index in addition. I think in the future, we have multiple indexes when we are evaluating patients. The cardiopulmonary coupling is based on coupling the signals from the heart rate variability and breathing, which makes the signal very stable. All the validation was done by utilizing PSG studies. So this is not validated by comparing this to home sleep apnea tests that are not sleep tests, they're breathing tests. So all the validation was by comparing the output of the algorithm to PSG. We present ODI on the report. We also present RDI, that is an autonomic RDI, which is an important difference from the RDI that you see on a PSG report. So I hope this explains what the technology is about. And the technology is a software as a medical device. So it has all to do with the algorithm, and you can actually use different devices to collect the data. But this device that you saw the image of is very convenient to wear. It's a low-cost device which offers dentists to screen more patients at a lower cost, which we at Sleep Image believe is the key. If the number of 1 billion people with undiagnosed sleep apnea is true, we need a low-cost validated technology. And there was a question about the Oura Ring. Oura Ring is a wellness device. It's not FDA cleared. So healthcare providers, including dentists, they need to be aware that if there is an issue down the road, you're not legally covered by using a wellness device. That's kind of the key difference. Also, Oura Ring has not been, even though you can find studies out there that says validation, that's just the name of the study. These studies that I have seen, they are just comparative studies, and that's not the same as validation.
Okay, thank you very much. That was great that you were there.
I have a question.
Sharon.
So with the cardiopulmonary coupling, do you have any contraindications, patients who have peripheral vascular disease or hypertension? Do you, even Dr. James said, in terms of interpreting the results, let's say, do you take that into consideration compared to a young, healthy patient who has no peripheral arterial disease or anything, or has it been shown that it's okay in that population as well too?
Yeah, so what you will see in patients that have a advanced arterial stiffness, they have lower sleep quality, which makes sense because this technology is focusing on the balance in the sympathetic and the parasympathetic system during sleep. Mm-hmm. And these patients have increased sympathetic dominance during the 24-hour period. So you can use the technology, but you need to be aware of that. If you have, for example, patients with a long history of diabetes, you should expect low sleep quality. Also, AFib, we say that AFib is a contraindicated, but that's only for the sleep quality. You can use the apnea measure.
Okay, thank you.
You're very welcome.
I really appreciated the insights that you presented, and but tell me again that you're using oxygen desaturation indices in an algorithm, and you're coupling it with cerebral blood flow. How are you getting the cerebral blood flow measurement?
No, so I'm sorry I wasn't clear enough. So we use you can either use a ECG signal or a PLEF signal, and you can collect that signal from wherever on your body. And that we use for the cardiopulmonary coupling analysis. And then to get the AHI, we need the SpO2 data. And we collect this with the ring on the finger. And the reason why our FDA clearance is the AHI from the sleep image system is comparable to AHI from polysomnography is based on that we measure sleep. And there are publications out there that demonstrate how cardiopulmonary coupling sleep correlates with PhD sleep. We display this a little differently. We have non-REM sleep and REM sleep, but when it comes to non-REM sleep, we do not have 3 sleep stages. We have stable sleep and unstable sleep. And there are publications that show the importance of stable sleep when it comes to cardiovascular parameters, both in adults and children.
So, I mean, what you're saying is really fascinating. Trying to figure out what's going on in something that you allow a patient to take home and to use for multi-testing. is so much better than relying on one sleep test in a lab, in an unfriendly environment for most patients. And so the credibility of what you're saying is predicated, if I heard you correctly, on you taking the data and then using PSG testing that is done in a one-day testing rather than on a multi-day testing. Is that correct?
That is correct. So to get our clearance, we used PSG data, and that is one night. And this is actually a very good comment, because there are publications out there by Dr. Robert Thomas, by Punjabi, where they're pointing out that this 1 or 2 night testing isn't sufficient in adults. The ASM recommendations is that 1 night testing in children is enough, because they do not have night-to-night variability. I've seen enough myself of multiple testing in children I do not agree with this. They have high variability, especially children with sleep apnea. You can see them with low sleep quality for quite a few nights until you finally see the drop in oxygenation and you have the sleep apnea that the complaint was about. So if you only do 1 night, you're missing a lot of kids. And I would like to ask Sanjeev to comment on this, if he agrees with this or not.
Unfortunately, I do not practice pediatric sleep medicine, so I can't comment on that, but I do believe there's significant night-to-night variability in adults, that's for sure. Depending on position spent, time spent supine, the amount of REM sampling, there is significant variability in night to night, but I can't comment on whether 1 night is sufficient for children or not.
I would just like to comment about the tinnitus cases and the correlation between it and temporomandibular joint issues. I think tinnitus is much more complicated than just the situation of the TMJ complex. And yes, it's really nice if it is, and it's simple, but I would suggest to you that some tinnitus cases are much more complex than that. And also to bring to the table the reality that one of the jokers in tinnitus is some type of trauma or concussions, which are influencing the whole muscular structure, oftentimes on the same side as the injury. And so to my colleagues, I would like to add that you have to have a history that is asks more than just whether you have a mandible is deflecting so many millimeters from the midline, and a cone beam that shows some type of degeneration of the condylar surfaces, for what it's worth.
Thank you. Does anyone want to respond before we close?
Yeah, if I can comment on that, I'm sorry if we left the impression that all tinnitus that's not hearing loss related is TMJ related, but it's certainly a certain portion of it is, and it's just another thing that's possible in the diagnostic differential. So it's something that is usually not considered within physician circles, and it is something to consider because TMJ dysfunction is often underdiagnosed, just as sleep apnea is underdiagnosed. It's just one other item to consider. It's not the end all and be all for all tinnitus. And if I left that impression, I'm sorry.
Yeah, and also, Lawrence, I think because the topic of today is an interprofessional collaboration, so we're not really focused on the actual case condition. We actually, our objective, Dr. Jen and I, doing this talk, is just to share how it is actually possible for me as the dentist to work with Dr. Morong back and forth, and then Dr. Jane back and forth, and we are taking care of the patient. So I think that's the reason why we left a lot of the actual the main maybe information about the tinnitus patient. So because we just didn't think that we're going to talk about the case, we wanted to share and give hope to the dentist that we can find a great doctors in the medical field to collaborate with us.